My name is Sangeeta Raja. I actually have been working in the development area for the last 30 years. I started my career as a United Nations volunteer and then worked for UNICEF, USAID, GSI, and then World Bank. Since then, I have created my own little company, which is women minority-based company in the US. And really, the purpose of this company is to really work with partners who are on the ground, really connecting with them and trying to come up with solutions that would work, bringing innovations from the private sector. And so really serving as a bridge between the private sector and the public sector. So that's the purpose of this company. I normally work with institutions that are already based in developing countries or low middle income countries. And I usually find a partner in the private sector, usually based in the high income countries.
So can you tell me, first of all, what has been the biggest challenge that you would say you've faced in your career to date?
Generally, in terms of the career, I think is trying to get solutions that are innovative, that could really change how we think about a problem and really applying it to the realities of a developing country. So for instance, the example of this AI work that we've been doing, the whole concept of AI is, first of all, very difficult. And trying to get it connected to really a public sector situation where most of the systems are very manual driven was a real hard to connect those two components. So really it's trying to come up, we know the solutions are there, but then the reality on the ground is very, very different and difficult, and trying to match those has been the biggest challenge.
Yeah, and it seems like over the past few years, we've seen a big increase of people moving towards more digital tools, more AI, more online platforms. Can you tell us a little bit about the shift as you've seen it?
Yeah, I think that the shift started almost in the 90s in the area of the supply chain work, where we started to realize that we really need visibility in the area of really understanding where the inventory was. And I think sort of trying to create IT systems that would actually start capturing that information. I think that's where the trend is kind of started and has really moved into the health information management systems. And now I think we're even discussing about trying to connect with getting patient data and really linking the patient directly to digital stuff. I think this is a trend that we don't have a choice. It needs to happen. It needs to move forward. And I think it will really help in really better understanding the trends of what's really going on. I mean, before it was really based on our perceptions or our experience. And now we can really rely on data that can drive that decision making.
Applying that to health campaigns, how have you seen that trend impact the planning or the way that health campaigns have been conducted?
So actually, I was really surprised to see very few digital application in the whole health campaign planning process. I've been involved in health campaigns for over the 30 years, and we used Excel spreadsheets, Word documents, and I thought I left that for over 10 years and thinking things would have changed, and was very surprised when I was looking at it again to realize that actually things have really not changed. And so I think there's a great opportunity to start really bringing digital capabilities in the area of microplanning.
So moving into microplanning specifically, can you talk a little bit about why it's important or some of the work that you've done in microplannings for campaigns?
Yeah, so right now, I think the way microplannings are done, it takes a lot of people who meet in various committees to really start planning these exercises. And this effort takes on every year after year after year. So there's a lot of opportunity to really try and make the whole process more efficient as we go along through the system, and trying to reduce the number of people who are involved, the number of tasks that are repeated again and again and again. So I think there is a need to change how we do business in terms of the microplanning process so that we are not doing the same things again and again. And so I think the tool that we have developed is hoping to try and cut all those processes that are continuously repeated.
So, are there any campaigns that you've been a part of that you thought had particularly good planning structures, or ones that you thought, oh, I can see a need for improvement in this area?
I think all campaigns do have a good planning structure in the sense that they have committees who are organized, there groups that are organized. So that is actually in a good thing, because what you've done is you've got to buy in across departments who are working together to really solve a one-time event. So I think those processes we do not want to lose. The fact that there's a collaboration across departments, collaborations against people. So those things are good. What I think needs to be changed is how we manage the nitty-gritty of the data itself or the planning itself. I think if we can improve those components, think would be really good. But I really do like the idea of the collaboration, and that's one of the things that we also in the platform wanted to make sure that as many people involved in the AI, in the microplanning, are still having access, that they're not being cut off in the microplanning, because we absolutely need the collaboration across departments, for the health campaigns to work, especially integrated health campaigns.
And this has actually led you to develop a tool for microplanning. Can you tell us a little bit about it? Just a short summary of what it is and how it works?
So basically what the microplanning tool does is actually it's an online web-based platform that enables individuals to initiate the planning process of the health campaign. So they're able to enter all the data into one system that is actually visible across committees and across people. So everybody's working under the one assumption and one approach. It has also taken out many of the factors that you had to do in the manually, like forecasting for medical supplies, forecasting the target population one should be, using for the campaigns and stuff. It has taken all those processes out and has basically enabled the AI machine to do that for you. So trying to take away work that should be really be done by machines. So we've tried to bring those two processes together to try and help with the whole microplanning, campaign planning process.
Let's talk a little bit about campaign integration. So, have you ever worked on an integrated or partially integrated campaign before?
So in Rwanda, it's a totally integrated campaign. They offer 5 to 6 services at one time. And so that's why we chose Rwanda as a place to really try and develop this tool, because if the microcampaign process that we put in place can deal with 6 to 7 components of a service delivery, then I think it can deliver with one. So that's been the case. In the case of my work in Mozambique, we were actually doing a distribution of bed nets and immunization that we pulled together. And it became extremely complex, partly because for malaria, we were trying to hit all households, pregnant women, and then for immunization and measles immunization, we're really looking for the ages 6 to 11. So the trying to bring these two components got a little more difficult than we thought it would be, even though at the end it's the same woman who ends up bringing the child for the immunization and is the same woman who needs the bed net for her household. But even despite all those combinations, it became complex in terms of the planning process, because there are 2 separate departments who are dealing with it, and then you're having to bring those 2 departments to work together.
So it seems like there's a little bit of there's an overlap between the population, but sometimes they're not always quite the same. Can you talk a little bit more about the benefits or the drawbacks of campaign integration?
So I think, first of all, there's great, the fact that we look from a consumer perspective, providing integrated health services an absolute must, because we do not want the woman to go 3 or 4 times to the health clinic or to her site to get the services for her child, for herself, and for the other households. I mean, that is a lot of amount of time that they're taking away from them being in the farm. So just from a consumer perspective, I think it's a great approach. From a cost-effective perspective, it does make sense in terms of the fact that it's the same people offering the same services. So if we're doing the microplanning process, it's better to just do it for everything at one time. However, we don't have the data to support whether that really, that efficiency or effectiveness is being achieved as a result of integration. But it theoretically makes sense. But even if we were not thinking from the supply side, I think it is absolutely necessary from a consumer side, because really we should try and make it as easy as for the woman or the household to come and get the services that they need.
And with the onset of COVID-19, obviously that's disrupted a lot of the different campaigns that have gone on. Do you think that that will accelerate the trend towards integration as people are looking for ways to save money or reduce effort? Or do you think that that's going to splinter the campaigns and make it a bit more difficult to integrate?
I think it will make it more difficult to integrate because I think in the next 2 years, we will be spending all our lives doing COVID campaigns. And unfortunately, all the other campaigns are just going to go on the wayside. And it will be one of those things, well, yeah, you can continue doing that, but we really got to get this up and running, right? So unfortunately, I think the whole COVID is going to have a negative impact. Also, COVID really, it's right now, the vaccination we have is from ages 12 to adulthood. And most of these campaigns that we are targeting is usually for the children. Deworming is till the age of 5, for measles is tried the age of 11. So 11 years old. So it really depends on, I think the two target groups is very, very different, and COVID is just going to take over our lives, which is going to be unfortunate.
So from a microplanning perspective, what other resources have you used in the past that have been particularly helpful that other campaign managers might also find useful?
So I think in terms of the planning, definitely, kind of the population. So data, you definitely absolutely need some of the data stuff, and trying to find these data sets, whether you're doing it in an AI tool, which we've developed, just makes life easier, but you still need all that data, and pulling that data together really helps you better plan your campaigns. Population data, knowing where your facilities are, knowing your state of supplies, all that, knowing your financing situation, all those components that we've just kind of made it easier by managing it under one platform. Those things still have to be planned, and things like Excel spreadsheets do the job in helping you organize yourselves.
What would your advice be to campaign managers either pursuing or planning integrated campaigns in the future?
My main thing is that really, I think you should think about it from the consumer perspective. First of all, work out. If you were offering the service, set of services for integrated health services, think it from the perspective of the consumer coming there. How is it going to impact them? How are they going to access the services that you're providing, the mixed bag of services that you're offering? Would that be the interest to the consumer? If we start designing the whole health campaigns from a consumer perspective, I think we'd get a better bang for the buck for the planning, rather than deciding, well, today we want to do deworming and family planning and whatever, because we get along, or it makes sense for us, or because we want to push this agenda. I don't think it would be the best approach in terms of doing services. And when we looked at Rwanda, we saw really there was not a significant uptake in family planning compared to some of the other ones. And so maybe that combination was not the best combination. We don't know, but clearly there was a drop in the women who took on family planning services. So that should be looked at and say, why was there a drop? Or why did consumers didn't take this on? Was it a bad combination of the services? Or was it that it was just a different target group compared to the rest?
Is there anything else that you would like to touch on, either about campaigns, campaign integration, or microplanning?
I think one of the things that I learned was, originally when I started this work, I really thought that the reason we did health campaigns was to really find the vulnerable, find those who have not received the services. And actually, doing health campaigns for the last 30 years of my life, I was always at this nagging feeling in the behind of my back. Are we actually, by doing this massive campaign approach, are we actually still delivering the services to the most vulnerable? Are we delivering to the services to those who are least likely to have received it through routine care? And really, it was never clear to me, because when you look at the numbers of the campaigns, it's based by population, and you have to, and they never remove those who could have received the services through routine care. So for instance, for example, for family planning, we have 60,000 in these facilities, in this district that we want to target, but yet 20,000 are already coming routinely to cover. But so we really need to target 40%, right? 40,000. But we don't do that in campaign planning. We just take the population number and say, this is the word people we target. So technically, we're giving the same service again and again to the same people. So that was one of the main things that I was sort of struggling with and trying to work out, how do we do that? what I've really come to the conclusion is that actually that's not that important. Yes, it is important to hit vulnerable communities. It is important to try and find those, but campaign has a bigger offers a bigger opportunity, which is really health awareness and health education, health awareness of all the other services that could be available through the public sector, through the healthcare system. And so that was really a learning experience for me, not realizing that actually campaigns have an altruistic goodness that we cannot actually calculate in terms of cost.